Hey guys, this is Dr. Mahajan from Mahajan Medical Center with another exciting edition of our webcast. And we got a very special guest today, a renowned cardiologist and a good friend of mine, Dr. Rakesh Sharma. He'll be on our show today and he's going to talk about the cardiovascular aspects of your health, how you can reduce your risk of heart attacks and keep your cholesterol down and all that good stuff which goes with reducing your heart disease, so you don't end up with him in the cath lab and him putting a stent. Nothing wrong with that. He's expert in putting all the complicated stents in this area. He has decades and decades of experience. So we're very excited to have Dr. Sharma on our show today, and it's going to be a fantastic show. And we're going to end the show today with Victory Breath, which is in yoga circle called Uji Pranayam. So that's a sound-based meditative exercise where you can breathe and concentrate on your sound coming out from your inhalation and exhalation. So that's one of my favorite breathing tests. So stick around with us and you will learn the techniques for that. Let's get you a little bit intro video about our practice, and we'll get started with Dr. Sharma in a minute. At Mahajan Medical Center, we care to listen to our patients. Proudly serving the needs of Tampa Bay in primary care for 25 years and counting. All right, so we're back. So just I wanted to make a point clear that, we just do this webcast to help educate our audience. In no way this is a replacement for you seeing me personally or Dr. Sharma personally. Anything we talk here is simply to educate our audience with, the heart-related topics today. All right, so with that, let's get our main guests on the show. We got couple of people already there, and Mr. Gupta said nice presentation. So that's very kind of you, Mr. and Mrs. Gupta. They're very loyal listeners to our webcast, so thank you for enjoying our brief intro. All right, let's get Dr. Sharma on the webcast. Hey Rakesh.
Hey there, Ranjan, how are you?
Thank you for coming to our webcast. I know you're very busy. You came running from Countryside Cath Lab, so that's very kind of you. So tell us a little bit about yourself. How long you've been in Florida. How you got interested in cardiology.
Dr. Mahajan, first of all, thank you for inviting me here in your wonderful broadcast. This is an amazing concept. You teach your patients on a regular basis. This is the best way you can do it. Well, to answer your question, the cardiology was always my love, and I have done cardiology training starting from Cleveland Clinic to University of Missouri, and I was a professor there for some time, and then finally I relocated to Clearwater, Florida in 1995. So I have been serving this community as a cardiologist since 1995.
Wow.
And it's been an honor.
That's 25 years, man. That's,
right.
That's amazing. The good thing about 95 is that I came to Tampa Bay in 95 too. We came together.
That's right. We actually met, if you recall. Yes. That's wonderful. Great memories. Yes.
We go back 25 years. We're getting mature, man.
Of course.
Now you have affiliation with USF as well, right? So
yes.
Tell us about that.
I am a clinical adjunct professor with the University of Arkansas, affiliate associate professor with the University of South Florida. The teaching was always a passion. I love teaching, of course, and love publications. I have written many papers in relation to especially these antiplatelet drugs, as we'll talk about that today. So being affiliated with these universities does add some flavor to teaching a little bit.
Right. So you got a whole lot of depth of knowledge, because I remember when you came in, you were doing AICDs and all the pacemakers, and there were, not as much differentiation between the invasive cardiology and EP. So you
That's
have
right.
a, breadth of knowledge of not
Right.
only, the
Right.
invasive field, what you are settled in right now, but all the arrhythmias and how to treat the arrhythmias. So you are, master of all aspects of cardiology.
Yeah, that was actually very interesting that when I arrived here, I did practice electrophysiology, intervention cardiology, and general cardiology, which is really not, it doesn't happen that way. But that's how I practiced when I was in the University of Missouri, Columbia. But now it has been super specialized, and my practice really focuses on office-based cardiology and interventional cardiology, which we'll hopefully talk about it a little bit, where I do take care of the patients who present with a heart attack.
Right. So now you're part of the Baycare, part
Right.
of Mount Plan, East Countryside, group
Right.
For the local area, though it's Baycare is huge, but you're part of the invasive team. So that's fantastic because, Baycare is one of the leading provider of healthcare in Tampa Bay. So it's good to, be part of the team. Um, we got Stephanie joining us, and Stephanie saying, great info. Thank you, Stephanie, for watching our show consistently, and we appreciate your, giving us a thumbs up. Please do comment. Dr. Sharma brings a wealth of knowledge. If you have any questions regarding cardiac conditions, though it won't be a specific advice, but we can give you general education about the topic. And if you need to see him, we'll put his phone number up there, and you can make an appointment. He has a office. Where is your offices, Rakesh?
So, Dr. Mahajan, the office is one right here in Clearwater, and on other one is in Safety Harbor. These are the two offices. We have an office in Dunedin too, of course, and North Bay as well. So I mainly practice out of Clearwater office and Safety Harbor office.
Okay, great. Tell us about your daily routine, what you do
So,
on your typical day.
so it's very interesting. Like today, I started with the cath day, and typically start my procedures 7:30. Like we'll talk about some of those patients who are having chest pain or who had a heart attack already are in the hospital. They need a procedure, and the procedure is called cardiac catheterization.
So let me stop
And
you there before we get to that, Rakesh. Let's just point to the patients why we are so, why is the heart health so important. Let's bring up
right,
the data from CDC side and get your comments on that. So per CDC, the heart disease is the leading cause of death for people of all races and sexes. So that's sad, but it is the true statement that once your heart stops, everything stops. So
that's
that's an important organ. The other stock statistics is one person dies every 36 seconds. So that's huge. Every 36 seconds, they die from the cardiovascular disease. So that's why we got you today to see how we can reduce the risk of getting to
right.
that point. And then, the other important part of the statistics is, and again, statistics is nothing to scare people, but just to bring how important the heart health is and how important it is to take care of it from early on when you're in your 20s, 30s, and 40s and 50s. So you don't get to that point that, we need to put a stent or we need to do a bypass or things like that. So the other piece which I got stuck in terms of the information is 1 in every 4 deaths is from heart disease. About 655,000 Americans die every year from heart disease. And then the cost is astronomical. About $300 billion a year is spent on cardiac disease. So these are, amazingly stock numbers, Rakesh. So let's get your take on that.
So, Dr. Mahajan, first of all, very good statistics you presented for your audience to make everybody aware that heart disease is very common, very prevalent. And once it strikes the patient, a lot of damage gets done. So it is absolutely important that each one of us take some steps to prevent it. Of course, once you come in in my lab already have a heart attack, that's a bit too late, and we take care of that, of course. But I think prevention strategy is very, very important. The only thing you don't have control in is on your genetics. You can't pick your parents, of course. You got the genetics, what you have. But however, managing your cholesterol, managing your weight.
We'll come to the risk factor prevention, but I want to talk about genetics for 1 minute, if you don't mind.
Sure.
We both are Southeast Asian origin men, and being men and Southeast Asian origin is double whammy for us. And I know you have experience with the API, which is the Physician Organization for Indian Physician Origin, and they have some work done on the coronaries and atherosclerosis of Southeast Asians. So if you don't mind commenting on why
Sure.
it's important, because we got a lot of audience which are of Asian origin, they should take better care of their cardiovascular health, Rakesh.
Excellent question. Excellent question. So, the folks of Indian origin, it's particularly very, very important. Number one, they have a dyslipidemia of different kind. For example, there are particles called LDL particles. LDL particles are a one particle of cholesterol, which is very dense and is atherogenic. When I say atherogenic, that means they can build plaque more easily, which can lead to the heart attack. Other thing is, in Asians, Indians, it is also seen that their coronary artery, the diameter is smaller. It is like, so it's sort of, if the plaque builds up and the diameter is smaller to begin with, it is likely they will have an obstructive blockage very soon. And cause, when the heart attack happens, there could be a major heart attack. So in Indian population, it is seen that, number one, the vessels are small in size. Number two, their lipid particles, especially the atherogenic particles, LDLs, are small and dense, which causes more atherosclerosis. So
that's a good point. And from internal medicine perspective, what I see and that's also true for Hispanic Americans, the local Native Americans too, that we share similar, A, anatomy in the arteries, and B, the atherogenicity in the, as you rightly pointed out, in the LP little a or LDL. But also, what I've seen in, more in the Asian and Southeast Asian is the truncal obesity, the central obesity. And as you know, the waist circumference has direct correlation with, either cardiovascular atherosclerotic disease or cerebrovascular atherosclerotic disease. So I think that's another higher risk of truncal obesity in the, that particular population. And also in the Hispanic and Afro-American population of truncal obesity is a major player for them to have a little bit more risk of coronary disease than the Caucasian American.
Very well said, Dr. Mahajan. Actually, abdominal adiposity, even though it is not as well published, in my opinion, it is one of the biggest risk factors. Once you have abdominal adiposity, you are also predisposed to many other things. Of course, atherogenic dyslipidemia means bad kind of cholesterol is there. Also, of course, diabetes. And once you have abdominal adiposity, it's very difficult. And that, even though we don't list as a traditional risk factor, like we list the diabetes, the high blood pressure, smoking, cholesterol, even though we don't list abdominal adiposity, I believe this is very, very important. So Dr. Mahajan, you pointed out very nicely that truncal obesity seen in many, many, even Asians, Indians, and even Caucasians here is a very important risk factor. And we all need to do the education on that aspect, and that will help significantly.
So let's bring a question here from Stephanie for you. Stephanie said, does it matter how old if you have an irregular heartbeat or a murmur? So I think they're two different things, Stephanie. The irregular heartbeat is more arrhythmias and murmurs are more leaky valves, and they are structural anomalies. And we do see cardiac arrhythmias in younger population as well, though not as common as, as we get older, the electrical circuits get older, and we see something like atrial fibrillation, which is the most common cardiac arrhythmia, goes up tremendously in the incidence as we get older. And cardiac murmur, is a leaky valve, and you can get congenital anomalies at a younger age, as well as, you can get the leaky valve with the valve not shutting as we get older, or with rheumatic heart fever, not that prevalent in Western countries, but that's another reason for leaky valve. Do you have anything else to add to that?
Yeah, I think it's a good question. So, Stephanie, you have a great question. Number one, yes, age is very important. If you have a murmur in elderly people, old age, and we're going to first think about, for example, aortic stenosis, very, very important. If you have a murmur in younger people, we're thinking about rheumatic heart disease, which is uncommon, like Dr. Mahajan pointed out. Now, as far as irregular heartbeat is also important. If you see in very young people and young females, we may be thinking of something like we call SVT or some just PAC simple, or if we see elderly people, then same irregular rhythm could be more dangerous. Of course, it could be atrial fibrillation, it could be ventricular tachycardia. So it is important. Age is a very important factor. Of course, other factors also has to be factored in.
Now we're talking about other factor. Good segue, Rakesh. Let's talk about other risk factors. So we talked about age as risk factor, ethnicity as risk factor, which you don't have control on. But let's talk about things which we can change and modify and reduce the risk of, coronary artery disease, or, aortic aneurysm or atherosclerosis of the big vessels, and also extension into the brain as well. All the body doesn't care where your blood vessel is, could be in your brain and cause, the same concept, which is good for the heart, is good for the brain, is good for your legs in terms of PAD reduction, is good for your ischemic bowel disease too. So, the blood vessels anywhere has same anatomy and same kind of, risk factors. So let's talk about the preventable risk factors for, since our topic is coronary artery disease or heart disease. So let's talk about that at length. So let's start with, let's say diabetes. You mentioned that earlier, and it's super atherogenic to be diabetic. How does it impact the coronary artery disease, the diabetes?
Of course, Dr. Mahajan, you're expert in diabetes management. Diabetes is a very, very important risk factor. We will maybe hopefully show you some videos and some where we can show you plaque. But what happens is when patient is diabetic, it works at the cellular level. End of the day, like Dr. Mahajan very well pointed out, vascular disease is very generalized. It could be in the brain, it could be in the heart, it could be in the peripheral arteries and so forth. Because all the vessels inside those has a very thin layer of cells called endothelium. So when you have a diabetes, that endothelium can be damaged over a period of time by virtue of very complex mechanism. So once that damage happens, and then the plaque or the platelet can start sticking to it, and the atherogenesis can start through a very, very complex process. So diabetes can cause this atherosclerosis in the small vessels as well as big vessels and all vessels in the body at very, very early age. And it is a preventable risk factor. As Dr. Mahajan knows very well, he manages diabetes patients every day.
So, the diabetes is, something which is difficult and easy. It's difficult because, you have to let go things you enjoy, the desserts, the cookies, the soda pop, the ice cream. But easy if you, understand that it's having high sugars increases your risk of heart attack and strokes and, amputation. The number one cause for amputation in this country is because of poor circulation. So if we can add a little bit more plant-based diet, and we're going to talk about diet at length a little bit, but since we got into diabetes and, the heart disease, let's just get the diet right in there here. So I'll add some concepts and you can add some expert comments on top. So, my experience is with diabetes and heart disease, the pathway is very similar in terms of diet. What is the pathway? The pathway is plant-based diet. More you're going to eat whole grains like beans and quinoa and brown rice. More you're going to eat fruits and vegetables, which is again plant-based. More you're going to eat chickpeas and hummus instead of butter. More your chances of atherosclerosis getting less. And then add some antioxidant, like we're blessed in Florida with berries of all kind, like strawberries and blueberries and raspberries. Any of these berry family, anything colored, for example, beets, those are phenomenal. So this all comes into what I call a Mediterranean diet, where people of Mediterranean origin, like Greeks and Turkish people and Italians, they have inbuilt, like a lot of herbs, a lot of olive oil, less meat, more fish. If you have to add meat of any kind, fish is good. Lean meats, if you have to, low fat, dairy, and eggs are okay. So if you do that consistently in your diet, you will have less heart disease, you will have reduced sugars, you will have improved circulation to your brain, so that implies less strokes and TIAs, and you'll have improved circulation to your legs. And more importantly, you'll get a good BM every day because you're getting fiber. And fiber is something we don't talk about as much, which is huge, in my opinion, in preventing atherosclerosis. Did I, cover everything, or Rakesh, you got
Yeah,
something?
I think you covered everything very well. I think the diet is a very important topic. As a matter of fact, whenever I get a chance with my patient, face to face, and if they are especially very obese, I will get a commitment from them before they leave. See, the diet is very complex and is very simplistic, like Dr. Mahajan just said. But you got to start very simple. You got to know what are bad foods. For example, if you eat carbohydrates all day, and it is not going to be good. Even you have to watch your portion control. But I think, Dr. Mahajan, you have covered very well all the things one has to do. But it is very important. The diet is the fundamental issue in prevention of any problems, diabetes, heart disease, and so forth.
Let's talk about high blood pressure. How does high blood pressure impacts the heart disease?
So, as you know, how the blood pressure is really created. Number one, of course, the motor is the heart. Heart is going to contract, right? It's going to create some pressure. But then, of course, we have blood vessels all in the body. And as we were young, the blood vessel was nice and compliant. They will, as the blood comes, it will reflect it. But as people gets older or they're diabetic, they become a bit non-compliant. So the pressure goes up. So once the blood pressure goes up, heart has to work harder. If the heart has to work harder, it can get thickened. And of course, the same thing, remember, the blood pressure affects not only arteries all over the body, but the arteries around the heart too. It can cause the damage in those membrane inside the vessels. Once the damage happens to the membranes, that's the beginning of start of the atherosclerosis process, which is buildup of the plaque. So even, for example, what Dr. Mahajan already pointed out, diet has a big factor. For example, if you just use the diet which Dr. Mahajan pointed out earlier, your blood pressure will go down by 20.
So that's the DASH diet, and which is again very similar to Mediterranean diet. It's again whole grain, plant-based, and it's been scientifically proven to lower blood pressure. So I know we're talking primarily atherosclerosis, Rakesh, but one thing I want to point out, that by lowering the blood pressure in a good range, you can also reduce the heart failure, and which is also a big crippling thing. Though it's we're not going to talk as much about it, but that gives you a huge advantage in reducing heart failure by keeping the blood pressure down.
Absolutely. You can reduce the heart failure, you can reduce the stroke, you can reduce the cardiac, of course, chances of having a heart attack. And of course, you reduce the chances of having a problem with the legs and the amputation. So it's a very important risk factor, which is again a modification.
Yes, it's a silent condition. You got to go for your physicals. You got to have a blood pressure machine at home, or you can go to Publix or any of those pharmacies, they have blood
Fiber.
pressure. Even the gyms have, the blood pressure machine. So if your top number is above, 145, 150 consistently, it's time to see a primary care and, get that looked at, especially if you have family history. Let's talk about, Rakesh, other risk factor, which is preventable, or it's harder, but, it's good to talk about is physical activity. Sedentary lifestyle causes more atherosclerosis, and active lifestyle reduces heart disease, reduces strokes, reduces, your sugar going up. So it has a huge impact, like your what you put in your mouth and how much you exercise in terms of your quality of life. Your take on it?
Absolutely. Physical activity is absolutely important. I will give you an example. There's a very healthy person walks into my office, and his complaint is, I'm short of breath. We done all the testing. There's nothing wrong with him. Well, you know what his problem is? Because he has never even done any exercise. He goes one flight of stairs, he's short of breath. And this is called physical deconditioning. It is an actual term. It is an actual diagnosis. So exercise is absolutely important. Not only it helps better metabolism of your glucose, improve your diabetes, it also helps your vessels, the blood vessel. They become a little more elastic. So the blood pressure goes down. It also releases endorphins, which makes you feel good. I think exercise has so many benefits, endocrinology-wise, even cardiac-wise. It should be a part of the diet, and exercise should be a part of our daily routine.
Yeah, we got Sandy saying, always so informative. Thank you, Sandy, for your kind words. We got a question for you from Daryl, Rakesh. Daryl saying, his father passed away at age 54. Our sympathies for you, Daryl, with a heart attack, and he's 56. So does he need to worry?
Good question. So that brings back the genetics. So anytime I see a family history of having a heart attack or cardiac death under age 60, that means you have a premature coronary disease in the family. Therefore, yes, you need to look into your risk factor. You need to make sure you are not diabetic. You got to make sure you are not hypertensive. You got to make sure your lipid profile is good. And clearly is absolutely important that you see a physician and get at least one time base exam done. And it is absolutely important. Like we pointed out right in the beginning of the broadcast, the family history is absolutely important and a very important risk factor, which we can modify, but you can modify all the other risk factors.
He's 56, Rakesh. Is there any indication with his dad having heart attack and dying at 54 for calcium score, CT angio?
So I think I will not jump onto the calcium score right away. But calcium score is a very good. I think the first would be getting a basic, let's say, lipid profile. I think, let's say he needs to see a physician or he needs to monitor his blood pressure, his hemoglobin A1C should be checked. All the risk factors should be assessed. Now, the calcium score is a very important test which has been recently quite a bit discussed. We use it to sort of classify, is the patient a bit high risk? So I could be aggressive in my management. So I can be very aggressive in my lipid management. That's where the calcium scores comes in place. And we basically, it's a simple test, and they measure the calcium deposited in the coronary arteries. And anytime you score more than 0 in that case, that's the bad news. That means you have some atherosclerosis.
I just throw it in there because I think, you don't want to do unnecessary testing, but, someone who has premature coronary disease,
Right.
having a image, having a number, it's a human nature.
So,
You start paying attention to your cardiologist or primary care endocrinologist to get your A1C down, get your cholesterol down, get your LDL less than 70, start exercising more. Now you see
right.
a picture. So
Yeah,
that's
no,
why I think the
no,
only
you are right
value-
on it, Dr. Mahajan. You are right on it by bringing that coronary calcium score. If I was like him, 56, and I will probably end up getting a calcium score, but before we do that, he will need to see a physician so that everything could be discussed, and then calcium score. Once you do it, and if he scores more than 0, you're going to become a little more aggressive in his management.
I just threw a fancy stuff for you, but we want to stay with basic stuff, which has more bang for your buck. So let's go back to the basic stuff. Quitting smoking. A
That's
lot of my patients stop seeing me because that's the only thing I tell them every time they come. They say, I got wrinkles on your face. I say, stop smoking. Then they say, I have chest pain. I see them in the hospital. I say, stop smoking. Then they have diabetes. I say, stop smoking. Otherwise, you lose your legs. And unfortunately, I wish I'm making this up, but it impacts you from head to toe in a very profound way. So it's a very difficult addiction. So it's nothing to make fun of their addiction, but if they can work on it to whatever it takes with medications, with patches, with gums, it will have huge bang for their buck if they can get off the cigarettes. What's your take, Rakesh?
great. Smoking is absolutely very, smoking cessation is the most important of all the risk factors. Now think about smoking for a second. When a person smokes, that causes a direct damage to the endothelium. Remember in my conversation, I've been talking about this inner membrane of these blood vessels inside this. That's called endothelium. In fact, smoking can cause a direct damage to that. Once the damage happens, that's the beginning of the process of those plaque buildup and the blockage buildup. And it also causes vasoconstrictions. The blood vessel, it can constrict a little bit. That means your blood pressure is going to go up. Smoking cessation is absolutely important. I know it is tough. We know. I always tell my patient, one of these days you will wake up and you'll make your mind and you will quit smoking. First thing, you have to make up your mind. Once a patient makes up his mind that he does want to quit smoking, it becomes so easy. But this is one of the most important risk factors we can talk about.
Right. So let's talk about the same thing in the same vein, and I don't think get talked enough as which is more acceptable in the society is consumption of alcohol. I think that's something we need to discuss with our patient. Let's say they're borderline diabetic, and as we age, the liver can't handle the amount of alcohol, especially the binges. If you do it on the weekends, it's going to have serious impact on your sugars because there's empty calories. Anytime your judgment is down, you're going to eat all the snacks with it. So it's not just the alcohol, but what get consumed with it, which you normally may be good with your not snacking as much processed food. But once you consume alcohol, you're with friends, you consume a lot of junk snacks. So that adds to the weight, it adds to the sugar, plus it's atherogenic. And not only that, it has direct effect on the heart in terms of alcoholic cardiomyopathy. What's your expert comments?
So I don't want to scare people on that. Of course, if you're doing a social drinking in moderation, that is of course okay, But if you're doing heavy drinking, binge drinking, a drinking to the level which can cause actually toxicity and toxic effects on the heart, that is a problem. No, you got to look into other factors. Remember, alcohol is going to increase your blood pressure if you're a daily drinker. Alcohol is going to increase your weight. It is going to get your diabetes out of control. So that, from that perspective, clearly you have to modify it. And if, of course, somebody is drinking heavy amount of alcohol, and that can cause liver damage. So, but on the other hand, if people are having social drinking in moderation, not on everyday basis, that clearly is acceptable. And then, of course, you got to find what kind of drinks you take, So.
Yeah, so I know the French wants to talk about the red wines all the time, but the data is sometimes good, sometimes bad. But I tell the patients, if you don't drink, you don't need the red pigment. You can get the red pigment from the beach. You can get the red pigment from the peaches. You can get the red pigment from anything which is red by Mother Nature. It gives you the same pigment which the red wine gives. So it's a little bit overblown, and then it's very hard to, if you have one drink, then second comes, then the third comes. So, if you have issues with diabetes, you have issues with heart disease, my suggestion is if you're past 50, knock it off, except for your birthdays, anniversaries, or, if you're with your friends, have a one or two, but otherwise don't bring it home. That's what I tell my practice. I know you're a little bit more liberal. All right, so let's summarize the risk factors, make sure we didn't miss any. And some people joined us a little bit late, so let me go over what you discussed and what can help the patient in preventing coronary artery disease or cardiac disease in general. So number one, we talked about losing weight. Number two, we talked about ethnicity, but we can't do much about it. But if you are, people of Southeast Asian origin or Native American or Afro American or Hispanic American, then you need to be more careful and be more aggressive in weight reduction. And the third thing we talked about, lipid lowering. If you have already atherosclerotic disease or diabetes, then you have to be more tighter with your lipid control, get the LDL less than 70. Otherwise, bad cholesterol LDL less than 100, we can live with that. But if you already have a stent in your heart or calcium buildup in your aorta on a chest X-ray, then you need to go below 70. So statins should be in the water at that time. Next up, we talked about diabetic management or keeping your sugars under control. The goal should be A1C. If you're younger, 6 or less or 6.5, if it's harder. But if you're older, then the newer guidelines are don't try to get too tight. We can live with 7.5 if someone is beyond 75, 80, but definitely try less than 7 if we can. The next thing we talked about is hypertension. If you can bring your blood pressure down, there's no ifs and buts. You can, by changing your lifestyle and taking the right amount of medication and not skipping your pills. That will have a huge impact in preventing not only heart disease, but strokes and heart failure as well. And we just discussed, the smoking cessation, absolutely paramount, that you do whatever it takes, hypnosis, Chantix, whatever it takes, patches, or, everyone has different way of doing it, but you got to absolutely, if you're serious about not getting heart disease, you got to quit smoking. And then we talked about alcohol in moderation and not doing binge drinking. Anything we missed, Rakesh?
No, I think you covered very well. That was excellent recap.
Okay, great. Let's move on let's share the screen, Rakesh. Let me bring the screen up. And I know you have some interesting things about COVID and the heart disease, so we'll leave that for the end. So let me share the screen and bring what you love, the invasive cardiology. So let me bring that up. All right, so we have a picture of the heart. So let's, for the layman people, Rakesh, can you tell them what heart attack is?
Okay, all right. That's a good segue to talk about this segment. So, like any organ, every organ needs a blood supply. Now, you look at the picture is right in front there. So you can see some of the arteries coming right in front of it. So same way, the heart also needs a blood supply. So it gets this blood supply by 3 arteries which runs around it. One to the front, one to the back, one to the right. Now, if any of those arteries gets blocked, means that part of the heart is not getting blood now. That is what causes the heart attack. That is when their muscle.
I think we had a technical glitch, but we'll get Rakesh back in a minute. So what he was talking about is the heart get not enough blood supply and the blood vessels get blocked. So then the muscle get ischemic, and then you start getting chest pain because the body is trying
60 minutes. And do you want me to repeat it? I hope everybody
just go from the muscle because we lost you in the middle. So you were talking about the blood vessels get blocked and the muscle get ischemic.
Absolutely. So what happened is, remember we talked all in this webcast that the blockages can happen in the arteries. If the arteries which supply blood to the heart muscle, if that gets blocked for any reason, And we talked about those risk factors. And if it is 100% blocked, now the supply is cut off. And once the supply is cut off, the muscle where that blood was going to go, that dies. It takes about 6 hours before it completely starts dying. However, the sooner we can get it, sooner we can open it, there's no damage. So that's what is a heart attack.
Let's underline this point. What's the importance, especially in COVID era? People are afraid to go to the hospitals. So I think we need to highlight this point that if you have chest pain and you are a middle-aged person, you are obese, you're diabetic, hypertensive, don't just assume it's gas. If you have risk factor, you're a smoker, you're diabetic, hypertensive, middle-aged, obese, chest pain is a heart attack unless proven otherwise. So the time is the essence, because after 6 hours, as Dr. Sharma pointed out, your muscles are gone, they're gone for good. And there will be some remodeling, but, you're losing a big chunk of your heart muscle. You end up getting cardiac cripple if it's a, widowmaker artery or something like that.
Right.
And you may get cardiac arrhythmias, and you may have a rocky course in the hospital if it's a major artery. So it's very critical, as Dr. Sharma pointed out, that if you have risk factors, you have family history, any chest pain is a heart attack, call 911. Don't worry about COVID. COVID we have to unfortunately live with now. It's something we have to go around. We can't die with the fear of getting COVID in the hospitals. And the hospitals have become better in terms of having separate, triage. So, and the time is the essence, because the muscles are dying and you can do something. So what can you do, Rakesh, to prevent the muscles to die?
So once that patient, let's say if somebody's, you pointed out very nicely, if somebody has all the risk factors and he developed this new onset of chest pain, and patient generally knows it, he is not feeling well, he's feeling tightness, pain is going to the back, he's nauseous, he maybe is throwing up, he's getting short of breath, all these symptoms that are happening, and he's not sure what's going on. Well, that most likely is the heart attack. And that is the time you promptly should go to the emergency room. What happens is, once you go to the emergency room, they are very well trained. The team, there's special teams for that. Promptly when you will come there, they will do what is called EKG. And actually, Dr. Mahajan has one EKG. He may be able to show you.
Pull it up. Let me pull it up. Since you brought it up, let me bring it up. Okay, hold on. Let me make it, in full screen. Give me 1 minute. All right, here we go.
So for example, I know for a lot of you, this may just look like just some lines, but when somebody see in the emergency room, all these bizarre segments are up, and they know this patient is having a major heart attack. Once that is decided, there's a protocol is set in place. We call it a code stemming. And let's say if I happen to be on call, it automatically comes to me, and it goes to all the other techs who's going to help me. It goes to the hospital administration. So everybody start heading to that direction, to the cath lab where the patient is. Our goal is we want to arrive within 10 minutes, 15 minutes, 30 minutes. We know which artery is blocked. And once I get the patient right on my table, I may go in right from the wrist, I may go right from the groin area. We promptly go inside the heart.
You want to show the video?
Rakesh? Yeah, let's show a video or a picture for your audience to make them understand better.
Sure. What we seeing here, Rakesh?
So it's if you don't see it very well, don't understand, don't worry about it. The bottom line is, once we have decided this patient is having a major heart attack, we need to reach out to that artery. So we either will go through the wrist or we go through the groin. You see some pictures, right? In this case, is going through the groin. The catheter travels all the way to the heart. And in this case, you can see that there's injection of the dye, and we can see the picture. In this case, you can see actually the blood is flowing through. But when that person is having a heart attack, you will not see any blood flow. It will stop right there. So promptly what we'll do is, our goal becomes to open that artery up. So what we'll do is, with our special equipment, we put a little guiding catheter, then the wire will travel like this. Once the wire travels, then promptly we may open up with a balloon. The balloon goes in right there, and that opens up. Now at this time, the blood flow has restored. And now Dr. Mahajan is showing that actually a stent. In the end, what we'll do is to prevent this blood vessel from collapsing, we may also insert a stent, which is sort of a special alloy, little steel, and that stent is against the wall. Now the artery from inside looks completely normal, blood flow is normal. Then your normal membrane, your endothelium will grow over that stent, and that stent will become a part of your body. And then you basically is going to be on some medication, which Dr. Mahajan and myself very, very passionate about it, that you must take your medication. There are some blood thinners you must take, for example, aspirin, Plavix, Brilinta, Affiant. There's a combination.
So Rakesh, let me tell what I tell all my patients once they've gone through with you these procedures for heart attack. I tell them, listen, you're going to get some special blood thinners from Dr. Sharma. Make sure you sell your jewelry on the eBay, but make sure you take those blood thinners, because otherwise you'll have restenosis of the stent. So it's very critical that they take the blood thinners as prescribed, like Brilinta or Plavix or whatever you guys are prescribing at the time. And then once they're done with that, high dose for whatever time frame, depending on the stent, 6 months, a year, depending on whether it's special stent drug eluting or not, they need to take the Plavix or the aspirin or both, whatever the cardiologist recommend, depending on their particular condition, for life. For life, unfortunately, unless they get bleeding or somewhere. Then also we try to, once the bleeding stops, we try to put them back at least on one antiplatelet agent, if not two. So what's your take on that, Rakesh?
So very, very, very important question. So these are, even though we loosely call these blood thinners, they really are what is called antiplatelet. So what happened is, Dr. Mahajan showed a very nice picture. There's a stent deployment. But what happened is, once the foreign body is inside, our cells, which are called platelets, each one of us has billions of cells, those. But those cells they can stick on those. Once they start sticking on those stents, and then the whole aggregate can form and the stent can close down, and that's really the devastation. So to prevent that, we take these medications called antiplatelet, loosely called blood thinners. These antiplatelets are, one is aspirin, commonly, very important you take it, unless you are allergic to aspirin, then we have other strategies. Other thing is, then we have medications. The Plavix is we've been using for a long time, but Plavix sometimes doesn't work on certain people. So new generation of drugs has come up. One is Brilinta, one is Affiant. So those medications in conjunction with aspirin has to be taken for some time. Now, if we put a medicated stent, the recommendation is 1 year. But with the newer stents coming up, the duration is getting shorter and shorter. But let the cardiologist decide it, because the decision is going to be made based on, did you have a heart attack, or did you have just a chest pain and we ended up finding a blockage. So it's very crucial that you take your medications.
Right. So not only the medications to prevent restenosis, as you rightly pointed out, with the antiplatelet agents like Brilinta and Affiant, and then aspirin for life, but also risk factor modification.
Absolutely.
That become more important. Now you already have one event that tells you that body is giving you ding dong, knock on your door, that future events are coming, whether it's more heart attacks, God forbid, or strokes, or PAD, or peripheral arterial disease. So those events are knocking on your door. So if you don't take, you start feeling better after Dr. Sharma did a great job getting up 2 a.m. and putting a stent, and you start feeling better, you have more energy. A lot of patients tell me that after stent they feel 10 years younger. That's all good. But 6 months later is when the tire hit the road, is when you got to start taking your medications, because now you're feeling good. You say, let me not take the statin. Let me not worry about going and see my primary care Dr. Mahajan to check my blood pressure or keep an eye on my cholesterol. And that's when, your chances of restenosis, chances of other events goes up. And that's where I think cardiac rehab fits in for older folks, which are, as you pointed out earlier, deconditioned, and getting them monitored post procedure so they get in a good habits. What's your take
Right.
on cardiac rehab?
Absolutely. So I think Dr. Mahajan really hit on a very important point. It is fine. You were lucky with the grace of God that you ended up in the right place and you got taken care in right time and there's no muscle damage. Beautiful. But that's where the story begins actually. No, you got to take care of yourself, because if the second event happened either because of stent closure or a new event, that is going to be very bad. So taking the medication on time and modifying all your risk factors, which all is going to help, which we talked about earlier, which is what is going to modify your lifestyle. As a matter of fact, once people adopt it, they feel much better than before they even had a heart attack or when they had a heart attack, because their trajectory of the life changes. If they were going to go downhill, now they're going to do just fine. So I think it is very important. Just procedure is not important. It is more important taking care of yourself. And the doctor can't do it all. You have to take care of yourself. It is sort of a shared commitment.
It's a teamwork, Rakesh. And
And
let's
they
get
work.
some comments here. Uh, Deborah is saying great information. Thank you, Deborah, for watching. Catherine Hyde, she's a old trauma nurse and a hazard nurse. She goes to hazard places all over the world to take care of people who are, and she's saying thank you for great information. Thank you for your service, Kathy, over the years. And we got Ray Davis. He's a very uh, good listener. Over last 1 year we have started this project. He and his wife, lovely wife Carolyn, supports us, so thank you both. Let's just spend a few minutes. I know you're tight with time and you got to go back to serving the heart disease for the community in Tampa Bay, and we appreciate you've been doing it for 25 years in Tampa Bay, Rakesh. But before we let you go, I know you brought a beautiful slide about the effect of COVID-19 on heart disease. So since we got you here, I want you to explain what this slide is about. So let me bring that up. All right, so we got this
So,
slide, and you want to walk us through?
okay. So let me tell you COVID-19 a little bit. Now, we all heard about COVID-19. We know it affects our lungs and all other organs, and it also affects the heart. The only thing on the slide is listed is that it can cause myocarditis, it can cause heart attack, it can cause cardiomyopathy, and so forth. Let me explain to you one thing which is very common. Remember, this virus has to get onto the cell somehow. It has to attach to the cell somehow. We all know we got receptors called ACE receptors. And remember, Dr. Mahajan used all the time those medication, ACE receptor blockers or angiotensin receptor blockers, all important. But those are ACE1. But there's also a receptor called ACE2. That is what the coronavirus or the COVID virus likes. So it will attach by its spike protein to that ACE2 receptor to get inside. Now, those ACE2 receptors are very prevalent in the lungs. They are also prevalent on the heart. So that means it can affect all the organs. Of course, I'm going to try to focus on the heart here. It can cause small heart attacks. And the slide which we're showing, if there's evidence of small heart attack, there's a study from China as well as from Mount Sinai. Those people don't do very well. Sometimes there could be inflammation of the heart, which is called myocarditis, and that can cause a problem. Sometimes the heart function can become weak and can have a heart failure. So, very important thing we recently saw, and in fact, the EKG Dr. Mahajan showed you earlier was actually one of the COVID patient. And COVID patients, one of the things which we have finally figured it out is their hypercoagulability, means the clot can form. Remember we were talking about the clot prevention by taking the medication when you have a stent? But when hypercoagulable state happens in the COVID crisis, that clots can form everywhere. In the brain, that can cause stroke. In the legs, can cause some legs problem. But it can be in the heart that can cause a major heart attack.
I think
But
we
that was not.
I think we've seen a shift in the care of sicker COVID patient now, Rakesh, in the hospital setting with they getting low molecular weight heparin as a standard protocol, the
That
lower
is
line.
right. Yep.
So,
And
that's
that's
what's
precisely the
recommended.
reason. Yep. That's
Yeah.
right.
And the lot of time what you were sharing with me before we started this talk, they may have the chest pains, and you see the biomarkers, the troponin elevated in the blood, but then you take them to cath lab and initial, I remember I had a cardiologist in New York, and they had didn't have all that experience now what we have or what you have, and they were taking everyone to cath, and they didn't realize that the troponin is going up because the inflammation, as you were pointing out, the
Right.
myocarditis.
That's
So
right.
it's very hard to cheese out. So it's very important to look at both aspects, whether it's
Absolutely.
myocarditis by doing the echocardiogram, or if you have a sense on the EKG that it's SC elevation MI, there is no ifs and buts. You got to do the cardiac cath, what we just showed earlier, and do the stent or angioplasty or whatever needs to be done.
Absolutely.
So let's just wrap it up. I know we are short on time, and cardiology is a fellowship. It takes 2 years, and then the invasive cardiology take another year, and and then heart failure become a fellowship now. So that's take another year. So you can you can talk 2 years on
Right.
cardiology, and we have only spent 30-40 minutes on it. So any final words of wisdom you want to give it to the patients to improve their heart health, Rakesh?
Yes. So I will say, if you think you have risk factors and you have a family history, think about it, what can happen. So modify those risk factors. That is a prevention strategy. Now, if you or in your family somebody already has a heart attack and already have a stent, that's a whole different ballgame. Now you need to be even super aggressive, and you want to prevent another event. You want to stick to the regimen. You want to modify all the risk factors, and you want to definitely prevent a second event. I think we have so many resources now, it is all doable. The bottom line is that it has to have a commitment from the patient, and it is a shared decision making, and it can all work out well.
Thank you so much, Rakesh, for coming and spending your busy time with us and our listeners about how to improve heart health. And I think one aspect I'm gonna teach them now, the breathing exercise, which all of my listeners love, has serious improvement in their heart health if they practice it regularly. It's like anything else, you just do it one time, it's not going to work. But if you do the breathing exercise consistently on a regular basis, it does help you, improve your, calming effect on the brain, and which has some indirect effect on your autonomic nervous system in terms of reducing your blood pressure, reducing your stress on the heart. Any catecholamine of any kind, any fear, any anxiety, any persistent worries has been shown to increase your risk of strokes, heart attack, and poor health. So breathing exercise, in my opinion, is a low-lying fruit. If we can practice it and do it consistently, along with the other things you mentioned, I think they will give them benefit. So we're going to do a breathing exercise. If you want to do with us, Rakesh, we're going to do a victory breath today. It's called, in the yoga circle, Ujjayi Pranayam. So if you want to do with me, that
Yeah.
would be great. All right, so let's
Wow.
do it together. All right, guys. So what I want you to do is sit on the edge of your tables and put your feet on the ground, and put your hands on your knees, and then turn your palms up now. In terms of just relax your jaw, and what we're going to focus on is breathing through our diaphragm, not through your chest, not through your belly, but through your diaphragm. So that we're going to practice first. So now what I want you to do is bring your hands up to your side of the chest, like the lower rib cage, and and focus on the expansion and it going back and forth. So that's when you know that you're breathing through your diaphragm. So you don't need to exert with that. So what you do simply is When you inhale, you will see your hands will go like this out, and when you exhale, they will come back. So that tells you that you're using your diaphragmatic muscles. And as I taught you multiple times in the past, there are three main muscles for breathing: the chest muscles, the intercostal muscle, which we use all the time, and that's for shallow breathing, which is all right, but that's not where the money is. The money is in the diaphragmatic breathing and the abdominal breathing, and we've done three-part breathing to show different parts there. So today we're going to only focus on diaphragmatic breathing, and then we'll come to the victory breath, which is a sound-based breathing exercise to focus on sound, what you create with your breathing, with inhalation and exhalation. The first part is getting the diaphragmatic breathing right. So breathe with me, inhale slowly, and then try not pushing your chest. Try, doing it through your hands going out in your lower chest. So that's where the focus should be on inhalation. The hand should go out. Again, focus should be your hands in the lower chest, not your intercostal muscle, not your abdominal muscle. Your solar plexus, yes, but not your muscles below that or above that. So it will be hard, but if you go in a calm state of mind, you can start focusing on breathing through your diaphragm. So do that for 5 minutes. Now you got that part. You can put your hands back on your knees, and then the next part, the sound part, I'll teach you. So the easy part in the sound is on the exhalation. The inhalation is a little bit hard, getting the sound that needs more practice. So what I typically teach people who are starting out, like folks like you, is to breathe in through your nose, and to make it easier, create a sound on exhalation through your mouth open. So let's do that. Breathe in through your nose, and then create a, like you're fogging a mirror. So if you have a mirror in front of you, you're trying to fog it. So breathe through your nose, and then fog the mirror. Some people call it Darth Vader breathing. So breathe through your nose. So you got that sense of. So how that comes in by constriction here. So if you focus on your trachea right here and make it a little bit tighter, it will come with practice, but that's where you're getting the. You don't want to create a sound from your mouth. The sound should come from the air getting tight up here. So that comes with practice, but I'm just giving you a flavor how it should sound on exhalation. So again, so you're fogging the mirror. Now that comes, as I taught you many times, we don't want the exhalation to come through your mouth. We always want the exhalation and inhalation to come through your nose. And so we're going to close our mouth and still create that sound. Let's do it again. Beautiful. So now you got a sense of the exhalation creating that sound of like a Darth Vader breathing, whispering breathing. Now we want to create it through inhalation as well. Again, the breathing is through your diaphragm. That's why it's very important to master the diaphragmatic breathing first. But once you got that, then you add the sound element. So let's do the inhalation and exhalation together with the sound. Good. What I want you to do is close your eyes now. And then when you're breathing in, I want you to focus on your in between your eyebrows. This is more advanced, but I'm giving you right there, and you can practice later. And when you're breathing out, you focus on just around your belly button. So let's do that. So that's very calming. So you're focusing on the sound aspect here. You do that for 5 minutes, and then you can stop creating the sound and keep your eyes closed and just do the normal breath at the time and focus on inhalation. You breathe in and get all the fresh breath in and breathe out, and what we call udana, or get all the bad breath out. So you just focus 5 minutes on Ujjayi breath, the victory breath, and 5 minutes, if you can, on just calmer breath, and then you can open your eyes gently, and that will get you nice relaxation. Or if you're getting into meditation, this will get you into meditative mode. With that, we thank Dr. Sharma for doing the victory breath with us and spending the time with us and sharing his wisdom. And he's a fantastic cardiologist and board certified in triple boards, Rakesh, right?
Right, triple board. Yes.
Super genius. And anytime you need any cardiology help or any, God forbid, stents or cath, he's your man. He goes to Mont Plant and East Countryside. So we'll put his number on our comments section. Let's see what we got up here in our Rakesh, thank you. And you have a fantastic Thanksgiving and wonderful weekend.
Thank you, Ranjan. Thank you for inviting me. Appreciate it.
Yeah. All right. So let's get the comments, here. And Stacy saying, thank you, Stacy. Thank you for watching. Beverly saying, and I never miss your Thursday information. Thank you, Bev. You're so kind. Nicole always is there for us. She's a newly minted RN, congratulations, and she is a wonderful supporter of Mahajan Medical Center webcast. Deanna is a fantastic nursing home administrator, retired now, and always have great comments and gives us a lot of enthusiasm for keep producing these shows. We're going to have our closing now. Be kind to yourself, be kind to the fellow human beings, and be kind to Mother Nature. And with that, we come to the end of our podcast. Do tune in next Thursday. We're going to have Jeannie, our wealth of knowledge on insurances, as we are into the period where we have to pick. It's open enrollment time for Medicare patients. So she's going to come and share and field your questions about Medicare, Medicare Advantage plan. And if you have any other queries about if you're turning 65 or changing doctors to Dr. Mahajan, or if you have friends and family who are turning 65 or they're looking for a primary care, think about Mahajan Medical Center. And with that, namaste and be kind.